So in many respects, whilst I recognise that there are patients who don't have inflammatory bowel disease, but for the large proportion in this country, it's a bowel and a liver disease. And increasingly, I think it's perfectly reasonable to think of it as one disease. Okay? So I try not to think of it as you're having two diseases, colitis and PSC. I try and think of it as you've got inflammation of the colon and inflammation of the bile ducts. And the bile ducts are inflamed and then cause scarring, which we'll come on to, and the colon is inflamed. And we don't know which one comes first, because in some people the bile ducts are injured first and we pick up the colitis afterwards, or the other way around. But that's the way I try and think about it. And actually, with the complex genetic studies that many of you have actually contributed to, we've been able to learn that we used to sort of think of people having colitis as being the same as the people who had colitis and PSC. But when you look at the genetics of someone with PSC and colitis and someone who's just got colitis, they're actually distinct. Okay? There's a little bit of overlap, but PSC IBD is distinct to just colitis by itself. Okay? So that's why I like to think of it really as it's probably one disease. It's patchy, and that's why it can cause problems. Okay? You saw the picture. This is just another representation of all the different bile ducts coming together, left and right hepatic duct, then common bile duct. Where it pinches off will cause the problem. So let's say you just pinch off just there, okay? Well, everything behind that will do badly, but the bit next to it will be fine. The bile will flow normally, okay? If I stick my needle in there, you'll see a bad part of liver. If I stick my needle in there, if the bile's flowing all right, you'll see a good part of liver. And that's the patchiness. But that actually is one of the challenges and it's one of the reasons why we don't do much ERCP, because it is so patchy. It's very rare that there's one bit that you can fix that makes a difference. I'm not saying there isn't occasionally a chance, but there can be, okay? That inflammation then causes narrowing. Narrowing causes blockage, okay? So the disease, as you know, anyone who's listened to me in clinic will know, I think of it in three ways: a tubular disease, a secondary scarring disease, and then the third bit I think of as independent is the cancer risk, okay? And that is distinct compared to other autoimmune diseases. And we don't know why, but it's a combination of genes and presumably something in the bile. But this disease does carry a cancer risk in your bile ducts, your gallbladder, and your colon. And that's a serious concern for everybody and something that causes an awful lot of anxiety, understandably. And me telling you that the majority of you will never get cancer, okay, doesn't really help. Although that's true, the majority of you will not get cancer. The vast majority do not get cancer. But that small minority, it's a big thing. And we struggle with that a lot in clinic. But that's the sort of the patchiness and the nature of PSC. And then something that we have worked very hard to make sure our gastroenterology colleagues really understand, and I alluded to by talking to you about the genetics, is that the colitis doesn't look the same as everyone else's colitis. It can be a marked colitis. It can be a colitis that can be quite tricky to treat and for us to need to sort of go up to sort of expensive medications. But really, in some things that are very distinct, one is that they need to push the colonoscope all the way around sometimes to see it. It's on the right side of your colon. And sometimes you only have information on the right side and you have no information anywhere else, okay? The other thing that you sometimes see is that the tail end is often spared. There's no information at all. And this is where it gets into quite complicated discussions about whether some people have got Crohn's or colitis, because Crohn's is historically thought of as a patchy disease. And that's why patients often said, well, you've got Crohn's because there's no information at the tail end, and then there's a bit which is mild, and then some sparing, and then some right-sided inflammation. I think we're increasingly pushing towards the terminology PSC IBD. That is what the colitis of PSC looks like. It isn't Crohn's, it isn't UC, it is PSC IBD. And why are we so particular about the colonoscopies every year? The increased risk of colon cancer is real, although I suspect that it's quite hard to prove, but our surveillance is so good nowadays that actually we're doing pretty well at preventing a lot of the colon cancers because we're so particular about the annual colonoscopies and the skills of our colonoscopy colleagues. The dye spray technology that they've got and the picking up of early dysplasia has really made a difference generally in terms of colon cancer in actually picking it up before it's true cancer. This is the challenge, however, okay? there won't be many of you in the audience who are good at liver biopsies, and that includes me. But one of the things that you do when you're looking at a liver biopsy, particularly when you're not the pathologist, is you count the blue dots. Okay? Blue dots usually mean cells. When you see a liver biopsy full of blue dots, you think, well, there must be a lot of extra cells, which are presumably inflammatory cells. One of the things that stands out when you look at PSC is there's your bile duct with a few cells around it, but mostly what's around it is scar tissue. Okay? There isn't actually much inflammation there. So by the time you're running into problems, which is unfortunately when we tend to meet you, actually the inflammation is gone for whatever reason, and what's left is scar tissue. And that's why it's been really hard to get new drugs for PSC, because it's unlikely that we're going to get a medicine that you just drop on and dissolves away scar tissue, because that's very difficult. They haven't really solved that for all the creams that they give you for anti-aging. Okay, so Boots will tell you that the cream will make you, get rid of your wrinkles, but they haven't really solved it either. And they can actually see, where they need to put the cream on. We can't give you the cream to rub into your bile ducts to get rid of the scarring. And again, analogous to colitis is that if I look after a patient, although generally Crohn's would be looked after by a specialist gastroenterologist, but if I look after someone with Crohn's disease often causes scarring, and you get a very tight blockage in the bowel and then some inflammation. And Crohn's disease is managed by the surgeons and the physicians. The surgeon removes the blockage, and then the physician gives very effective drugs. And with their very effective drugs, they prevent the scarring from coming back. But those very effective, expensive drugs do nothing to that scar. The surgeon has to remove it. The problem is that your bile ducts are, 8-9 millimeters in diameter, buried in your liver, so we don't have that option of remove the bit that's blocked and then get on top of the inflammation. And that's why it's been coined the cirrhosis of the bile ducts, which is a slight sort of misnomer, but that's a terminology that a guy called Michael Manns in Germany's used, which is a good way to perhaps think about it from your perspective. That's so much scarring around the bile ducts. Okay. Why do you get autoimmune liver disease? Well, that's a long story, but the short answer is it's complex, but then everything is. It's your genes and it's your environment. And by environment, we don't really just mean what you've ingested, what you've breathed, what you've put on your skin, what you've eaten, but we also mean nowadays your bacteria in your bowel. And not one bacteria, but the family of bacteria. And we're learning more and more about how your genes determine the bugs that are in your bowel, and how your bugs in your bowel interact with your genes, and also how they make bile acids. So we always knew that the bile acids were metabolized by bugs in your bowel, but the bugs can metabolize things and may change protein levels subtly. So you can't change your genes, and our diet over the last 100 years in the Western world has clearly changed enormously. So if you actually look at the trends for a number of patients being diagnosed, for example, with colitis, there's a clear increase this century. And there are parts of the world, like parts of Canada, where there's clearly kids more and more getting colitis. It's clearly increased. And one explanation is your genes won't have changed, but your bowel bugs have. Age is important. Ethnicity is important. You can't change that. That's probably genes. Gender used to be, it's still, strictly speaking, probably a male-predominant disease, PSC, but we are increasingly seeing more women, and in some cohorts it's now 50-50, and so we don't actually have that sort of distinction between men and women as the historic literature suggests. And those genes can be associated with other autoimmune diseases. We have patients who've got PSC, they've got ankylosing spondylitis, they've got type 1 diabetes, so they've got more than one autoimmunity going on. And it comes together, and there is always going to be a bit of bad luck. Something must come along as the trigger, okay, or the final match. And that's why it's so hard, because it could have been something that happened 10, 20 years ago, and clearly you can't measure it today. What do we do to unravel all of that? Well, what you normally do is you start off with the easy things and you slowly move through the harder things. And that's where PSC has been quite hard to study. Actually, it's really easy to study genetics nowadays, so that's why there's been so much work on the genetics. It's easy because you're also happy to give us a blood sample. It's very quick to isolate your DNA, okay? And that DNA is very stable, and we can send it anywhere we like to, and the machines are now so good they can read the whole thing. Okay, so there's lots of genetic studies, and your genes don't change. So they are the same from the day you're born to the day you die. So that's been an easy thing for us to do, and then we compare it between other diseases. So we know a lot about the genes. We don't really know very much about, we know the names, but we don't really know much about what those genes do, because for each gene there'll then be a story. And unlike some other autoimmune diseases, there hasn't been a whole set of genes that all look like they're all telling the same story. In PSC, it's more like each gene tells a different bit of the story and they're each doing something. Whereas in some diseases like PBC, which is the small bile duct disease, we saw whole pathways light up, and they were all like, it was like following a motorway, and all the exits, they were all lighting up as being part of the disease, and it's like shining a light towards the problem. But in PSC, it's more complicated. We have relied on animals. There isn't a very good animal model of PSC. That is a challenge. Some drug companies are obsessed and they will only develop a drug that works in an animal first. Other drug companies have the exact opposite and talk about the billions of dollars they've spent on drugs that work in mice and don't work in humans, so are entirely now focused on human-only studies where they use human tissue to really find a drug. Because mice are similar but different, so they help us at times and other times they may mislead us. But we've learned a lot from mice. And then there are patients who have got disease that looks like PSC but we know isn't. And we've learnt from them. So, for example, actually, kids with cystic fibrosis do actually get bile duct disease in a small proportion of cases. And some of them actually end up needing liver transplants. It's quite rare nowadays, but they do. And actually their disease looks like a bile duct disease, quite interestingly. And actually it turns out that that chloride transporter, which is so important for their chest, is also important for how you make bile. So we learnt something about how you make bile. We know that there are people who've got immunodeficiencies. They don't make the right antibodies, and they then get infections in their bile, and those infections never go away because they have an immunodeficiency, and the infection gives them something that looks just like PSC. So that helps us understand that infection is probably important in PSC. We learnt a lot from liver transplantation and from previous treatments for some kinds of liver cancer about how important the blood supply to the liver is. So if one of our patients has a liver transplant, I always wind up the surgeons. In fact, I got caught out once because I didn't know the surgeon was standing behind me. But I was just telling the patient day one post-liver transplant that it was all about plumbing, okay? Because it is. For the first year after liver transplant, it's largely about plumbing, okay? And a lot of the problems that we have are about connections, okay? They don't like me to say that, and Tamara nearly smacked me, but it's about tubes. You've got to join the bile ducts together, you've got to join the portal vein together, you've got to join the artery together, you've got to join the hepatic vein. You can't get away from that. And if there's a blockage, there's a blockage. And that's the rejection part's the easy part that the physicians look after. But if you have a blockage to your hepatic artery, then your bile ducts can look like PSC immediately. And it just tells us that the blood supply to the bile ducts is very important. And then there's the last bit which we'll talk about, we always talk about in Birmingham, the Adams hypothesis. That's Dave Adams, our boss. Which really says, well, okay, let's think of this not as PSC and colitis, but let's think of this as one disease, PSC IBD. Why is it that you've got white cells in the bowel and white cells in the bile duct? Is it because the white cells that are supposed to stick in the bowel stick in the bile ducts? And that is a pretty convincing hypothesis. It's not the whole answer to the problem, but there has got to be a link between the bowel and the bile. It can't just be a coincidence that you've got both. And that's where some of the new therapies may help in the future. Okay. Now I'm going to talk about what those blood tests mean for you. So the first thing is that I said you're all individuals, and textbooks are good because it keeps me in business to write new chapters, but they don't apply to the person in front of you, and that's where we've found it quite hard. But we've learnt a lot by looking at lots of patients. We've learnt that if only the small bile ducts are involved, you do quite well. That's actually obvious. I just told you, if you've got billions of small bile ducts, you can last longer. You get one bile duct, the common bile duct blocked off, you're in trouble. We've also learnt that there's actually quite a big spread. There are more patients out there with PSC who've got milder disease than we thought. That's good, okay? But of course it is a challenge for the patient to know whether that's you or someone else. But those patients didn't used to travel all the way to the Mayo Clinic in the US, and so wouldn't have gone into the paper. They would have just stayed in their local hospital because they were well. Okay? This is a study, for example, from the Netherlands, where they've got about 800 patients from across the Netherlands, and the patients who never made it to the transplant centres actually had a 21-year survival. The patients that are coming to the bigger centres obviously needed transplant, so were a bit sicker. So we know that in fact there are different groups of you. We do know that your blood tests help us give some idea as to what's going on. And alkaline phosphatase, that bile duct enzyme, is quite good at predicting what's going to happen to you. It's not good enough on an individual basis to tell you for sure, but if your alkaline phosphatase remains nearly normal, okay, then you do much better than if your alkaline phosphatase stays high. Okay? That's helpful because that's one of the simple things we use to try and decide who goes into our clinical trials. It's not perfect because unlike other diseases, in PSC you get cholangitis, you get infection of your bile ducts, and that can tweak your ALP phos, and so one day it can go up and then down and up and down, and we only ever measure, one point in time, so it's not really reflecting the area under the curve. But it is true to say that your alkaline phosphatase is a barometer of what's going on, and if it's persistently normal, then you do better. The challenge came, and you don't really need to worry about the graphs on the slide particularly at all, with Urso, which of course is a quite controversial topic. It remains a controversial topic. I think I usually say that Urso doesn't do anything, particularly if Roger Chapman's in the room, because it gives him a heart attack. Okay, but we've looked at Urso for 30 years. So in my simplistic way, if it was the panacea, we'd probably know by now. Okay, so it may have a role in some people, but it's clearly not enough for most people. That's the best way to think about it. But Urso drops your blood tests. But yet we couldn't prove that it made you better. So it just talks to the fact that the disease is much more complicated. So something that drops your blood test doesn't always mean it's going to be good for you, because these graphs, if you were to take your time to read them, would show that it really didn't matter how your ALP phos dropped. It wasn't because Urso dropped your ALP phos that you did well. Okay? So that's where it's quite complicated. The other things that increasingly are coming into practice, which we do like, and I think patients like, are what we call non-invasive markers of scarring, or bedside tests. So this is graphs around Fibrous Can, okay? And lots of you will be starting to have Fibrous Scans. It doesn't hurt, there's no pain, it's like pinging your liver, watching a bit of jelly wobble, and then working out the stiffness of the jelly, okay? The stiffer your liver, whether that's scarring or inflammation or infection, then the worse your liver disease is. And these are just graphs showing that if your scarring is good, then you do better. If your scarring is higher, so if you measure your Fibrous Can reading, that it predicts that you'll have a stormier time. We don't yet know what the best cutoff is, and we're still learning how to use it and to repeatedly use it, because actually if you measure it more than once in the day, it's slightly different. If you measure it and you've had breakfast, it goes up slightly. If someone else measures it, there's some variation in it. But we're still learning, and the goal, I suspect, in the future is eventually you'll get this something once a year or once every other year, and you'll plot it, and it'll give you some idea of where you're headed. And the change over time will be the thing that's most useful to predicting what happens. So we are going to see more people getting Fibrous Scans, and I've talked about other MRI technology. Okay, so then how do we evaluate patients? So there's something about the liver, something about the peculiarities of PSC, something about how we know who's doing well and who might be in trouble. So the evaluation is actually pretty simple. You want your doctors to do the right blood tests. There's actually pretty simple blood tests tell you what's going on, looking at alkaline phosphatase. You make sure there are no other causes, and people talk a lot about IgG4 associated disease. It's probably on your forums and websites. Just to reassure you, IgG4 disease is a real disease, but it is vanishingly rare. Okay? And so whilst we definitely encourage everyone to exclude it, it is still very, very, very rare. It's 100 times rarer than PSC. So, for the odd patient, it's great, but for the majority, it hasn't changed. You'll get an MRI. We tend not to do ERCPs unless there's a blockage, unless you're yellow, and we think there's a blockage that we can help. You may need a liver biopsy. That might be because the MRI is normal or because you want to be in a part of a clinical trial. And everyone will get at least one colonoscopy in their lifetime. If you've got colitis, you'll get one a year. If you haven't got colitis, you'll probably get at least two separated by 5 years. And some people then continue every 5 years for everyone. But I tend to then rely on symptoms if 2 colonoscopies are normal over a long period. But everybody's slightly different in how they do things. The MRIs meant that we're picking up patients earlier and earlier, which is good, because what that means is that that's probably the best time to treat ultimately when we get the right drugs before there's too much scar tissue, because I told you getting rid of scar tissue, like any scar tissue, whether it's in your skin, or whether it's in your lungs, whether it's your heart or your liver, is going to be harder than getting rid of inflammation. So we are diagnosing patients earlier. That's a good thing. It adds some of the burden to you as opposed to us. So early diagnosis comes with huge anxiety, okay, because then you're not sure what's going to happen to you. And it may have been that, you know, in days gone by, you would have not known about what was going on, and you would have pitched up 15, 20 years later to the doctors. So it is something that comes with a price, but I think it's the only way we'll overcome the roadblock to new therapies. And then I always show this slide about why clinical trials are so important. So one of the good things about autoimmune liver disease up until now has been that all your drugs have been very cheap. Okay, so the health service were happy about that. One of the bad things about cheap drugs is, and drugs such as UDCA, where people don't think of them so much as a drug, is that doctors don't necessarily worry about evidence before they use them. They'll say, well, Urso's safe. Surely the reason it didn't work at 8 milligrams per kilogram was you didn't give enough. We'll try 12, we'll try 15, we'll try 20, we'll try 30. Surely more is better. One of the important messages is that we had to do a clinical trial to prove that at a very high dose, UDCA seemed to be bad for you. We would never have known unless those patients who took part in that clinical trial had not taken part. So the patients, these are graphs of real people, okay? They've helped us understand for the next 5 or 10 years that high-dose Urso was a mistake. It doesn't help the patient, and it's why clinical trials are so important. The other flip side of it is, which is important but can be frustrating for patients, is that we are in search of an expensive drug. Okay, I'm happy to be on YouTube and reporting to say that, because trust me, the minute you're an expensive patient, you are noted in the NHS. Okay, you know, you will not. I look after patients with Wilson's disease, so for something else that I squeeze in. Very, very rare liver disease, copper absorption. Drugs have previously been quite cheap. Drug companies increased the price of the drug. That's their choice. It's a business. We live in a free market. Okay, you can't have it both ways. Okay, but overnight, when that drug price went up, for the first time, I got an email about that disease. Okay, overnight. Okay, because it immediately went red on the and that's how the health service works. And what we need for our patients with autoimmune liver disease is expensive drugs, because then you will get, you know, noticed, and then someone will say, surely all these patients should be looked after in a certain way. Why don't we know what happens to patients with PSC? Where do they all live in the UK? You know, they're going to cost us this amount of money. We need to know all that. Whereas when you're not an expensive drug, you know, they've got other priorities. It's not that they're not interested. They're just busy, and they start at the top and work down. And if your drug costs 50p, then, whereas your drug costs £100,000 a year, they start at the person who costs £100,000 a year. So we're looking forward to an expensive drug, because I think it'll actually be good for you. It will be good for us because we'll be on the map. Okay. The other reason I don't believe Urso works really is the transplant rate. So we haven't seen a drop in number of people needing a transplant for PSC, despite Urso being around for 20, 30 years. Okay. The red dots are the patients in the UK having transplants for PSC. If anything, over the last 8 years, there's more people having a transplant for PSC, and the average age remains too young. Okay, you know, if you're having a transplant in your 30s and 40s, that's too young. That's when you're, you know, starting families, etc., etc. So we have to make major inroads into this disease. So, what are my sort of comments about treatments? So, I don't object to people using Urso, but I won't let them have a high dose. I don't believe it works, so I don't actually start it myself anymore. Many of the clinical trials that we now do require you not to be on Urso. That's to try and help us get a better answer from the clinical trials, because if we have a mixture of patients, some on, some off, it could affect our results. I don't believe Urso stops you getting colon cancer. There's no evidence. I do believe a good gastroenterologist can help you along the way, so good colonoscopy is very important with, you know, the right person doing it. There are times when we make it hard and autoimmune diseases look like other autoimmune diseases, and so there are times when there's a lot of inflammation and sometimes it looks like autoimmune hepatitis. I don't have a hard and fast rule, but for some patients they will need steroids, okay? And I'll see whether it helps their liver inflammation. It doesn't always, but that has to be individualized, and that will require liver biopsy. We do look for the very rare diseases, and very occasionally you pick up IgG4 disease and you treat it and it's great, but it is very rare, and we are interested in your quality of life. We'll come back to that. Okay? Other little things that I think are really important, you know, most of you will have ciprofloxacin at home, at least that's what I do. I think all of you should have ciprofloxacin at home, really. Okay? You're all sensible enough to know whether you should take it if you've got pain and fever or you're feeling ill, and trying to get a GP to prescribe it for you on a Sunday night, you know, even, you know, is just an extra barrier because it's a safe drug. You're not going to take it if you don't need it. And don't let anyone do an ERCP if they haven't given you some antibiotics before they start. Okay? So if you're going to have an ERCP, the person doing it needs to know that you're special. PSC is different to the rest of the patients, and you definitely want your antibiotics. Sometimes antibiotics long-term is very helpful. There is a complete schizophrenia, it would be a good word, for how we use ERCP in PSC. In parts of Europe, patients have ERCPs nearly every year, every other year. Whereas if you're in one of, say, our program in Birmingham, it's very rare, and James does ERCP, I don't, but James Ferguson still does ERCP, but we think really hard before our patients have an ERCP because of the risks, okay? Because we don't want you to get infection and run into problems. Now, we don't know who's right and who's wrong, okay, but our outcomes appear to be the same, so that tells us that that's why we haven't changed our practice yet. If technology gets better, you know, dare I be rude and say if the Japanese get even better at fibre optic technology, and they are, and there's now, you know, little telescopes that go up your bile ducts, we may have to reconsider that. We may get to the point where the technology is amazing and you really can put tiny little wires into the bile ducts and deliver therapy. And of course, that would make sense, wouldn't it, to actually deliver the therapy where the inflammation is. So it may change in 10 years' time. There may be developments in endoscopy that mean you really can go right into those bile ducts, see them, take biopsies, and deliver treatment. But we're just not there yet. Transplant's very important. We can talk about it in the questions and answers. We don't always know when the right time to do it. Colonoscopy I've gone on and on about, so you've probably got that message already. We generally like you to have an ultrasound once a year. Helps us look at your liver size, looks at your gallbladder, and we don't go screening your family. That's a question that comes up sometimes, but it's pretty unusual. It's not unheard of. We do have a few patients, but to have brothers and sisters or mothers and daughters or sons and fathers with PSC is uncommon. Beyond the liver, as I said, it goes all the way from being asymptomatic to being a real challenge for your quality of life. Okay? And we know if we measure your quality of life using standardized surveys, your quality of life is impaired. Fatigue is very important, very poorly appreciated by the medical community, very hard to treat, however. The fatigue of PSC is probably even more complicated than just chronic inflammation, because many of you, you know, it's in the name, isn't it, have got low-grade chronic cholangitis, low-grade chronic infection. And if you listen to PSC patients, you sometimes talk about having waves of fatigue. And that may be that you've had an attack of cholangitis and just didn't know about it. You have a bad few days and then it clears. Because your body's trying to always help you. You don't always need antibiotics, your body does a lot. Itch really is an awful symptom. Can't sleep, you know, it feels like you've got ants under your skin. It's very tricky in PSC because the itch is all around bile duct obstruction, and sometimes our drugs aren't particularly good. We would transplant for pruritus, severe obstruction. I'm afraid things like transplantation for fatigue, it doesn't work. Fatigue doesn't get better. Okay? Don't forget your poor old bones amongst there. Okay, so we should be getting a GP to think about your bones at some point. If you've got both colitis and PSC and maybe been on steroids, well then your bones are, you know, a problem. This could be done better, I think, by clinicians. We're not very good at asking you whether you itch. And then if you do tell us, we don't always treat it. And sometimes when we treat it, they don't use the right medicines. Number one, so there are things you can do. Antihistamines are not terrible, but they don't really help the itch. They just help you sleep. But that can be sufficient. Okay? And then we've got bile acid sequestrants and then drugs like rifampicin, which can be very effective. Not perfect, but very effective. Okay? Again, that's a job for me to try and improve the recognition across the UK in terms of non-specialist practices. And then what about where we're headed? Okay, to end up with the research. The research is hard. Okay? Generally, research doesn't work. Nearly always when you send a paper, what you get back is a tirade of criticisms, okay, about what you should have done better. Okay? And even just publishing a paper takes about a year from submission till it comes out. Okay, so that's why most people sort of shy away from it. But Dave's been at it for a long time. Okay, so he's nearly up his 20 years from his idea to actually trying out the drugs. So this is this concept that white cells that stick in the gut, maybe they stick in the bile ducts because they've actually got the same signature. These are the signature molecules. These are the locks on the door, essentially, and then they'll stick together. And we've started to give patients anti-VAT1. It's a really hard clinical trial. We're working really hard, but we've dosed up patients in our phase 2 study, and we're going to continue, and we're trying to open centres across the UK. So we're trying to get Nottingham, Oxford, hopefully Newcastle, maybe Royal Free, maybe elsewhere. Hard, but we're trying really hard to do that. You'll know that Takeda have a drug that blocks this molecule, alpha-4 beta-7. Some of you may already be getting that drug for your colitis. It's a fantastic drug for colitis. We've started to use it in Birmingham because it's approved by NICE, because it's an expensive drug, so there's a lot of discussion about it, but it's really very good. It's called vedolizumab. Okay. There's probably going to be a trial of vedolizumab in PSC. We're just waiting for the details, etc., etc. So that's that idea that you block the inflamed cells getting into the liver. The other thing that is really attracting most attention is so-called choloretic drugs. So this is a loose term, a bit like Urso. So Urso is actually given in gram quantities. It probably displaces toxic bile acids, and that probably makes your bile a bit thinner and a little bit less toxic, and that's why the liver tests get better. But it's clearly not enough in a disease like PSC. But there are lots of companies out there trying to get better drugs, which are given milligram quantities, or even less, which have very powerful effects on the biliary tree. And so, for example, in PBC, your sort of sister disease of small bile ducts, this is now the first new drug in PBC in the last 20 years, obeticholic acid. So that shows it can be done. We can take a rare disease and we can get a new drug to market. Okay? So PBC patients will get access to a new drug, hopefully in the UK 2017 or 2018. Okay? And that's taken, a lot of work by that company. Has been at it since 2002. Okay, and before. But they've got there, okay? Maybe it'll help PSC, okay? But there's going to be a clinical trial opening of the NGM drug, NGM282. Okay, that'll be a trial you might be interested in. That's going to be a bit like a beta bile acid. And then I'll just mention a little bit about a derivative of Urso called Urso, which some of you may have heard of. So this is what happened to patients given Urso. So Urso is ursodeoxycholic acid with a slight chemical modification. And what that does essentially is make your bile produce more bicarbonate. So bicarbonate then repels some of that toxic bile, and so you have a less toxic bile. That's the hypothesis. Okay? And this was a dose-ranging study across Europe of patients with PSC. Everyone had to stop their ursodeoxycholic acid, so they accepted that. They all had to come off Urso. And then they were trying to find the right dose. And you can see that it is optimistic. At the top dose, your liver test got better by about 25%. Okay? And it was reasonably dose dependent, so that's very promising and that's very encouraging. And so they're going away now thinking about how do they prove whether this drug works. This was a 3-month study. To prove a drug works, I'm afraid in PSC you probably need a study that lasts 2 years, at least. Slow disease. But we're hoping that they'll come back with a 2-year study where patients across Europe will get the chance to try Urso instead of Urso to see whether or not it makes a difference. Just the fact that it's going into phase 3 is exciting, but just remember it's very hard to get drugs all the way through to market. Other things we're doing here in Birmingham, we're thinking about so-called stem cell therapy. It's not really stem cells. These are cells that you can get from the umbilical cord after mothers are given birth. We call them stromal cells, and they're actually anti-inflammatory. So we're pretty close now. We've nearly ironed out all the hurdles that have been put in our way, from making the cells to the regulatory hurdles and the permissions, that later this year we'll start giving patients with PSC stromal cells to see whether they're anti-inflammatory. It's going to be a proof of principle study, mainly around safety. That's where you start, looking a little bit for efficacy. But this takes the problem in a different way. It says, well, hell, you've got a really inflammatory disease. Let's not worry about which pathway. Let's try and turn all of them to anti-inflammatory and see whether it makes a difference. Okay, so that's exciting. And then it always comes up in discussion, what about your bugs in your bowel? Okay, so of course if you were, particularly for pediatric patients where this has been talked about a lot, and particularly on the east coast of the US, it is true that some antibiotics, particularly vancomycin, if given to patients with PSC, do appear to reduce your liver tests. We don't know what that means, and there haven't been properly randomized controlled studies. But it does speak to the point that your bowel is probably very important in the disease. We've published, Norway's published, the US has published that the bugs in someone with PSC's bowel are slightly different to someone else's. Okay? So changing those bugs may be important. Things that we're thinking about, we're a little bit nervous about leaving patients on vancomycin continuously because we see the other side. So our transplant ward has a lot of patients who've got resistant bugs. You would have heard the chief medical officer talking about the risks of multi-resistant bacteria. Well, they are real, okay? We do have times where I've been asked to approve a drug to be flown in from outside the country because it's the only drug that's available, and would the finance director approve that drug? So we got to the point where we literally are onto our last antibiotic for patients. So we're a bit nervous about the concept of using antibiotics continuously in a disease that will last 20 years. But Tariq Iqbal, one of our colleagues, is a professor of gastroenterology here, is doing a study where he gives you a fecal transplant, so someone else's stool, and actually they're doing that for a trial of colitis. So there will be a chance for patients with PSC colitis to go into that study to see whether or not changing their bowel works. So many of you will know that if you get something called C. diff, which is that antibiotic-associated diarrhea, okay, Clostridium, the best treatment, it may not sound very nice, but by far is a fecal transplant. It's unbelievable. So where patients have failed everything, overnight after a fecal transplant, they're cured. Okay? Which it makes sense, you've basically got rid of the wrong bugs. But it really does work, and it turns out that Birmingham is the place that's worked out how to make the fecal transplants particularly well. So that's something we've got on our agenda. Okay, so I think I've probably said too much.